Hello and welcome. Thank you for joining SIO today for our July webinar on improving sexual health care and oncology, care considerations for female and transgender cancer patients with Dr. Lauren Walker. My name is Morgan Denault. I am with the SIO staff for today's webinar. If you have any technical audio difficulties, please feel free to send me a chat in the chat box. If you have any questions for our presenter today, Dr. Lauren Walker, who I will introduce here in a second, please send them through the Q&A box at any time located in your toolbar. We will go through all of your questions at the end of the presentation. Also, as a friendly reminder, this webinar is being recorded and will be posted on the SIO YouTube channel for your reference. Today, we have with us Dr. Lauren Walker, a sexuality researcher who holds an adjunct associate professorship in the departments of oncology and psychology at the University of Calgary. She's also a registered clinical psychologist in Alberta, Canada, specializing in sexuality and intimate relationships. Her passion is working with couples and individuals who are interested in enhancing their intimate relationships and sexual lives, and with people who are experiencing sexual difficulties. The focus of Dr. Walker's work is developing sexual health programs for people experiencing sexual difficulties. She also prioritizes translating science and research about sexuality into real-life education for everyone. Her mission is to help people grow in the areas of sexuality, intimacy, relationships, and self-care. Her research aims to improve healthcare providers' offerings of sexual health care to patients, and her social media presence on Instagram aims to reduce the stigma associated with sexuality, mental health, and health. Dr. Walker has collaborated internationally with co-investigators and patient care organizations to improve cancer patients' access to sexual health care. She also has written 50 peer-reviewed articles on psychosocial and sexual adaptation to cancer and given over 125 invited talks and conference presentations. Thank you for being with us today, Dr. Walker. Now over to you.
Thanks so much for the introduction. I'm looking forward to sharing some of my knowledge with you today about the development of cancer care related programming for cancer survivors in the area of sexual health. So I'd like to declare that there are no conflicts of interest to be aware of as I give this presentation today. You will certainly learn about some other products and tools and things that could be of help to patients, but I do not have any economic relationships with any of those providers or companies. So I'd like to give a little bit of an overview of what to expect from this talk today. First, we'll begin discussing how cancer can affect sexual function. I will talk a little bit about relationship to body and how gender can play a role in some of the challenges that come up with cancer survivors and their relationship to body. We'll review what we can expect from sexual response and what some of the challenges are to what we have considered to be normal sexual response. And we'll talk a bit about sexual dysfunction as well as some of the common problems that cancer survivors experience. And then I intend to walk through two common examples, including a variety of interventions for those problems, including low sexual desire and sexual pain. So when we're looking at the prevalence of sexual concerns, we know that sexual difficulties are incredibly common among cancer patients and survivors. We see rates as high as 80 to 90% in gynecological and prostate cancer patients, and rates even higher than 60% in breast, colorectal, and bone or blood cancers. So while we may get lots of attention for those with reproductive cancers, we certainly see really high sexual concerns rates in other types of cancer survivors as well. And these concerns are associated with lower quality of life and greater mood disturbance amongst patients. And often sexuality is the most common cited life-disturbing side effect of cancer treatment. And it's one that, if left unaddressed, does not typically resolve on its own. It's something that typically requires intervention and support. Whether patients receive that support or not is another issue. So we know that in studies across all types of cancer patients, across any spot in their disease trajectory, at least 43% of them are reporting some degree of sexual problem, but only 13% had stated that they had received treatment for those problems. Now, this was in a Live Strong report, but I highlight it, even though the 43% is low, I highlight it to show that there's really quite a small number of patients who are actually getting help and support. So we know that the gap in sexual health care is high. More and more attention is being paid to this in recent years, and hopefully we'll see this continue to improve. But really, poor provider communication about sexual impacts in oncology is very well documented. And when we look at barriers, these tend to be commonly cited due to lack of time and competing topics to be discussed, a lack of expertise and training of the healthcare provider, and fear of patient discomfort. So healthcare providers often thinking that if they talk about sex, it'll make their patients uncomfortable. And the recent ASCO guidelines, which were also adopted in Canada, place the onus on the provider to initiate discussions about sexuality. So we can't wait for patients to bring it up, assuming that if it's important to them, they will ask questions. We as providers need to ask questions of our patients. And often that can be done with general statements like, cancer treatment can impact sexual function. Do you have any concerns in this area? And then if they don't, great. But if they do, they now know that they have permission to talk to their provider about these concerns. You might also be thinking that this could be dependent on the type of provider. Maybe those who are more specialized in reproductive health care would spend more time talking about sexuality. But we see even that fewer than 50% of gynecological oncologists will regularly gather the sexual history of patients, typically focusing on their cancer care. So certainly we need to focus on improving communication. With regards to cancer treatment and impacts on sexual health, many different types of treatment can have compounding effects. So certainly when dealing with radiation, we notice that if there's pelvic radiation, there's often a direct increase or a direct impact on pelvic health tissues, with decreased lubrication to vaginal tissues, scar tissue development, which can reduce elasticity, and of course, fatigue. As well, other types of radiation can include scarring, lymphedema, and fatigue. We know that chemotherapy has differential effects, and in some cases, some drugs will cause gonadal failure, which can be temporary or permanent. And also nerve damage can occur, which we often hear about this in the context of peripheral neuropathy, but certainly also acknowledging that this can impact nerve function in the genital regions, which can impact sensation and pleasure. With endocrine therapy, obviously we're manipulating hormones, and so menopausal effects are common with vaginal dryness, and as well as impacts on desire and erectile capacity. Now, when I speak about erectile capacity, we know that erectile capacity is something that is not dependent on anatomy. We see clitoral erections, penile erections. So certainly as I talk about erectile capacity throughout the course of the presentation, let's consider that this is about genital blood flow and engorgement and capacity for arousal across all genital types. With surgery, we see an impact in blood flow or nerve function to sexual areas of the body, particularly when we are dealing with surgery to the pelvis, as well when looking at full body, altered body image, and body scarring. And we know that body image is directly related to sexual capacity and can be very influential in one's ability to be able to engage and be comfortable engaging in sex. Of course, stem cell transplant can also be quite influential and cause similar changes to estrogen deficiency. Of course, stem cell transplant is often accompanied by a variety of different treatments. And then with certain types of stem cell transplant, there can also be an increased risk of vaginal graft versus host disease, which can be quite profound in terms of the impact directly on genitals. So as many of these treatments also overlap in terms of the resulting outcome being estrogen deficiency, I thought it would be helpful to review some of the symptoms that are associated with genitourinary syndrome of menopause. I've actually added a couple of items to this table, which is probably a table that you're familiar with coming out from the NAMS statement, but we are seeing dryness, difficulty with pain and discomfort, problems with arousal and desire, as well as difficulties related to direct changes in the vagina, including vaginal foreshortening, architectural changes, including the labia minora, in some cases looking as if they've been reabsorbed into the body, so less structurally identifiable. Tissue fragility, which can lead to bleeding during sexual activities. And so definitely noticing lots of these impacts in our cancer survivors. This graph shows the association between lower estrogen and increases in sexual problems. And so if you're looking at the darker bars, these are people with lower estradiol levels. And you can see that vaginal dryness is quite common, approaching 45% of folks reporting those problems. And then pain with frequency and intensity rates are hovering around 25 to 35%. And then burning or irritation can be a smaller subset of the sample, but certainly still a significant proportion of people. So for those of you who work with breast cancer survivors, you might also be interested in knowing about some of the profound vulvo-vaginal changes that can occur in folks on endocrine therapy. So the following slide is an explicit slide with some images just to forewarn you. And these are images of a patient who had experienced on the left 5 years of letrozole and 2 years of anastrozole. And you'll see significant changes in both vulvovaginal health in terms of atrophy, and also you can see on the left that loss of labial architecture. So as a psychologist, I find it really helpful to see images like this so that I have a better understanding of those profound changes that are happening to our patients. So when we are talking about these changes, it's not easy to adapt to. And certainly I think an important component of that is helping our patients adjust to how they feel about the changes that have happened to their body. And we know that many patients report diverse experiences in relationship to their body from their cancer treatment. On the one hand, we may see some patients who are reporting gratitude that their body endured treatment with strength, while others might report distrust and betrayal at their body for getting sick and letting them down. So very different reactions people may have in relationship to their body. Many patients report grief and loss about the changes that have occurred to their bodies, ranging from weight loss, hair loss, changes in stamina and strength, changes in hormones, and loss of organs, in particular body parts. For example, those with reproductive cancers often struggle not only with their body image related changes that I've previously mentioned, but also with those loss of organs that are often most socially associated with being a woman or being a man. Mastectomy, vulvectomy, hysterectomy often leave cisgendered women feeling less than, less feminine, less whole, and less sexual. For some trans and non-binary patients, grief and loss may also be present, or they may also experience a different set of emotions attached to removal of such organs. For example, gratitude or affirmation, to be free of such gendered anatomy that may have been a source of dysphoria or concern for them prior. In an essay that I co-authored with my colleague Tristan Bylash, who himself is a transgender male advanced ovarian cancer survivor, entitled Spare Parts, he described feeling both sets of feelings simultaneously, both euphoria at his hysterectomy, yet sadness at the loss of those organs, which were still considered very much to be a part of himself. And sometimes that may be surprising to people that complex set of emotions is present, that people can feel both gratitude and also sadness. Furthermore, treatments that are accompanied by constant medical examination by physicians and fellows and residents and med students, it sometimes feels like there's just a whole row of learners who are observing and participating in assessments of very intimate nature, especially for certain types of cancer, that this can lead to people often feeling quite medicalized with regards to their bodies and disconnected from the idea that their body is a sexual entity. And this can be particularly challenging for transgender patients who often experience or have experienced historically prejudice and judgment and a lack of trauma-informed care within their healthcare experiences. We know that many trans men avoid gynecological treatment altogether because of a history of negative healthcare experiences and because of intense feelings of dysphoria when they are accessing such care. And I think through my work with Tristan, who himself is a patient advocate, and through the work that we've been doing with our publications, we're really learning that by far the best thing we can do when we treat our patients is to model open, inclusive, and affirming care to all patients respecting all gender identities and presentations, and querying comfort and discomfort with procedures that we may take for granted as standard procedures that are required as a part of your cancer treatment. And really that we need to do that with sensitivity, and we really need to use a trauma-informed approach with all of our patients, because the likelihood is that they have experienced some trauma at some point in their life. An additional challenge that is experienced by both cis and trans folks, but that is disproportionately heavy for our trans patients, is the gendered expectations of how our bodies are used, in particular for sexual acts. And in a study that I'm currently conducting on sexual expression in transgender and non-binary folks, one of the most important adaptive strategies that I have learned about through these interviews for facilitating satisfying sex is beginning to let go of these gendered expectations for how penises or how vulvas and vaginas are expected to be used in masculine or feminine ways within sexual interactions. And so this is something that I'll follow up a little bit more on in our next slide for how we can support patients to begin to challenge some of those assumptions and create some more adaptability or flexibility. So I noticed on the registration of folks who registered for today's webinar that there's a variety of different types of healthcare providers joining us, and patient advocates and representatives. And so this is particularly, I aimed this as what can we do as healthcare providers, but I really think that as a society, we can start to have, an influence in having these conversations. So we know that one of the biggest predictors of better sexual adaptation amongst cancer survivors is sexual flexibility. And this is that sense that when met with a sexual challenge, that we can start to think a little bit more flexibly about what do we do to engage in sex? How do we define it? How do we use our bodies? Can we use sexual aids or toys or medications and integrate those into our lives? And so the more flexible we can be, the less rigid we are about things needing to be a certain way and fitting in a certain box, the better likelihood we will have of adapting. Now that is helpful for any of us in the audience that we may be faced with health challenges or effects of aging that impact sexual function in the future. And so we really can start to be thinking about, can we challenge some of these assumptions, these dominant myths, these social constructs that we have learned living in the society that we are living in. And really, I believe that these changed beliefs start with conversations. So have these conversations with your patients, have them with your friends, have them with your partner, so that we can start to challenge some of those assumptions. And really, I think that we can help patients begin to challenge those gendered expectations regarding sex. So I'm going to give you two examples of this. The first one is that the vast majority of people, when you think about what is sex, they think about penetrative sexual activity, typically penis in vagina sex. Now, that's cis heteronormative. It's exclusive to other folks who are having different kinds of penetrative sex, and exclusive to a variety of different kinds of non-penetrative ways of engaging in sexual activity. So my first message when I'm working with my patients is that sex is not intercourse. Sex is all of those activities that you engage in that create sexual arousal and pleasure and enjoyment, and that can be partnered, that can be unpartnered, that can be directly involving genitals, and maybe not even involving genitals. So we need to move away from this imperative that intercourse is sex, and that's what we need to be aiming for, because many of our survivors and patients going through treatment, this is simply not accessible to them. They may not have the energy, they may have physical limitations, and then they may feel like these other activities are less than or not good enough. But really, that's something we need to start to challenge. A second thing we can challenge is the orgasm gap. You may or may not be aware of some of the statistics among cis women and men that suggest that in your average partnered encounter, 95% of heterosexual men will always orgasm, and 65% of heterosexual women will. If you start to look at women who are partnered with women, those rates increase to 86%. If you look at the influence of relationship duration, we see that women who are in relationships for 6 months or longer are 6 times more likely to have an orgasm during their sexual encounters. So there is differential pleasure that is provided through intercourse to each party engaged in those activities. And particularly for women, clitoral stimulation is a requirement to be able to have a satisfying sexual encounter that includes orgasm. So again, this is another piece of evidence that we really need to move away from this assumption that intercourse is the be all and end all, and in fact, empower women to be able to expect that they can experience pleasure and that that should be a strong motivator for them to engage in sex. Whereas sometimes I see with cancer survivors that they engage in sex not for themselves, but for their partner, maybe feeling like they won't be a good partner if they don't have sex with their partner. And so I think giving permission to not have sex if it hurts or if you don't want to or have the energy to, and giving permission to spend that time on other kinds of sexual activity that will be more likely to increase pleasure. So let's talk a little bit about sexual response. So in the 70s and 80s, some very important studies were done with participants in a lab environment to demonstrate what was happening during a sexual experience. And there have been a few additions and modifications to this model, but first they started to document signs of arousal, that arousal would increase to the point of being ready for penetration. Again, a strong emphasis here on intercourse, that folks would have an orgasm and then have a resolution period where the body returned back to its regular state. Researchers came along, Helen Kaplan, and added in the phenomenon of sexual desire or interest. And in this case, really took a linear approach to say that these things happen in order and that there's little deviation from that. However, when you ask people whether that model fits for them, more than half of them will say that it doesn't. And so here are a few examples of some deviations from that normal sexual response. You'll see in the blue line that this person is having multiple orgasms as a part of their experience. You'll see in the yellow line that this is a relatively short period of arousal buildup and a quick orgasm and back to resolution. So this might be someone where we would consider this being a very truncated or maybe even a premature type of sexual response. With the red line, you'll see that this is an example of someone who's not orgasmic, but is still experiencing good degrees of arousal and hopefully sexual pleasure. And then this purple line is an example of someone who's experiencing arousal, but not necessarily sufficient levels of arousal to be able to culminate in an orgasm. And they may or may not be satisfied with that experience. And I would say, particularly in our cancer survivors, the biggest deviation we see from the normal model that I presented before is desire is not present, or it's very difficult to cultivate. And so we can still have these sexual responses even when desire isn't present, and we'll talk about that shortly. So I like to think about a variety of domains of sexual function, including desire, arousal, orgasm, adding in as well, though, pain, satisfaction, and pleasure. So if you're thinking about assessing, you may also want to consider changes in these, frequency, and intensity. And when diagnosing sexual dysfunction, a really important component is that there is not just a functional impairment, but that there is also distress associated with that impairment. And we think about sexual distress as being a myriad of emotional responses, typically relating to frustration, stress, worry, or anxiety. And you may want to assess that with your patient. So this is an example of a 5-item scale used to assess sexual distress. The Likert response is from never to always, and you ask the person to think about the distress they've experienced in the past month related to their sexual problem. If you don't have time to get them to fill out a 5-item questionnaire, There's some good evidence that simply asking this first question, how distressed are you about your sex life, is also very highly correlated with the overall score from the 5-item measure. So always ask about distress, because if someone has a functional problem, but they're not distressed by it, they don't have a sexual dysfunction. So in the context of cancer, obviously we see lots of low sexual desire, difficulties with arousal and orgasm, prevalent sexual pain or pain associated with intercourse, lots of body image, sequelae, and then that disconnection or disembodiment. Now, I would like to offer a few assumptions before we dive into some treatment here, that anything related to vulval or vaginal health may be relevant to both cisgender women and trans men or non-binary persons, provided that they have retained a vulva or a vagina. Anyone who has a trans woman who has gone through any kind of bottom procedure, bottom surgery, is likely quite familiar with the variety of treatments that we'll talk about around managing vulval health, but certainly can be encouraged and supported in that, as these are difficult treatments to maintain use of. Transgender women and non-binary folks may also experience erectile and arousal difficulties. And of course, special considerations need to be taken when considering any type of hormonal treatment, as hormonal treatment is a really important affirmative part of transgender healthcare. Yet we know that many of the treatments for hormone-dependent cancers can be difficult to navigate, and that we need still much more research in this area. So the two examples that I'd like to highlight are really common concerns: low sexual desire and sexual pain. I will attempt to be fairly comprehensive in providing some different options for these, but also recognize that my bent is a bit more on the psychosocial side, but I will review some medical medication options as well. First of all, I'd like to acknowledge that when introducing these treatments, there can often be some challenges around treatment adherence. So the majority of people that are dealing with low sexual desire will take one of two pathways. They either report stopping having sex altogether, or they carry on having sex, but they are going through the motions. They're not really enjoying it. They're not experiencing arousal. And we know that this is really harmful for maintaining a healthy sexual relationship, both in a partnered or a individual context. So I'd like to suggest that we don't do those things, that we change the way in which people are continuing to have sex. And with sexual pain, for example, I'll introduce dilation as an option or treatment, but we know that adherence rates are really quite low, so 40% or so by about 1 year after introducing this treatment, and that there are a number of reasons why this may be the case. So when looking at adherence, I think one of the important things is that we need to acknowledge that simply educating our patients or telling them about treatment options is not enough to promote behavioral change. So we actually need to do more than simply fill our patients' brains with more information or knowledge about things they could be doing. So certainly it is important to do that information provision, but also we need to build upon that. And so using the information, motivation, behavioral skills model as a foundation for many of the interventions and programs that my team and I have been designing to support cancer survivors, we think that it's really important to also work with patients based on what their values and motivations are. So understanding what are the things that they, from a values-based perspective, are going to be open to using, and what will motivate them when perhaps motivation fluctuates. There will be times where they're not very motivated. And secondly, that we focus on self-efficacy. So building up their skills and capacity and belief that they can use these things is equally important, because if you know that there's an option, but you don't think you would be able to use it, you're simply not going to be successful with using it. So let's review some of the options for low sexual desire. So for those physicians in the room who may be interested, there certainly are some medication options that have been A little bit controversial. So we know that there's some debate about testosterone and its role in improving desire. The literature is critiqued a little bit because they tend to study folks who are already engaging in several satisfying sexual encounters per month and then see some improvements in that rather than working with folks who are not engaging in sexual activity. And that there's lots of side effects and little long-term safety data around testosterone with similar risks to estrogen treatment in hormone-sensitive in hormone-sensitive cancers. We thought that flubanserin would be this really great pill to be able to improve desire in women. What we have found from these studies is that the success that is touted is largely an increase in frequency from activity in a very small amount. So moving from 1.7 times a month to 1.8 times a month in 10 to 12% of women in clinical trials. Certainly, they also include some other limitations that may not fit for many people's lifestyle. And another consideration is looking at antidepressant medications or other medications that people are taking that may have some hindering effects on sexual activity and considering modifying those. But what you'll see in my coming slides is that desire is largely contextual. Hormones, medications, yes, they may play a role, but probably the most influential thing is the kind of sex that's being had or the context in which that sex is occurring. So to give you a take-home message, I really want to help you differentiate between two types of sexual desire, spontaneous desire and responsive desire. We've all been socialized to think that spontaneous desire is the only kind of desire or it's the best kind of desire. This is that random, innate, unprompted desire or urge to be sexual that just kind of hits you like a lightning bolt. Versus a desire that results from sexual stimuli that follows from a sexual context. And I would like to argue that especially in our cancer survivors, responsive desire is going to be far more influential and valuable than spontaneous desire. So this comes from the model of circular sexual response, which is attributed to Rosemary Basson and her colleagues out at UBC. And this is a bit of a complex model to explain. So if you would like to have the full explanation, I have about a 15-minute video or so here. You can see the Vimeo link at the bottom. You can go check that out on your own. But what this model is introducing is that we don't necessarily need spontaneous desire to be motivated to have sex. We may have a bunch of other reasons that we might choose to be sexual or have motivation. And in this image, they're highlighting emotional intimacy as being one of those reasons. So it's maybe not an urge to want to be sexual, but rather a desire to be close to one's partner. When you have a motivator and you're willing to proceed, you are open to experience, you have some sexual stimuli, you start to become aroused, you pay attention to that stimuli, so you're engaging and paying attention to what's happening. Then we start to experience arousal, and that's when desire kicks in. That sense of, ooh, this feels good. I want this to keep happening. And that is also desire, and it's no less effective or important than spontaneous desire. So hopefully we're left with emotional and physical satisfaction throughout this experience. But really the important piece here is that spontaneous desire may be a part of your experience, but it is not a necessity. So when I talk about different reasons where we want to have sex, emotional intimacy may be one of those, but there's lots of reasons why we might choose to engage in sex. So I'm not going to spend too much time on this, just being aware of my time here. But there's a very interesting study conducted at the University of Texas with college undergrads, I will say, where they were surveyed about what was the reason that you had sex the last time you had sex. And they categorized their reasons into these different 4 categories here. But you might be interested to know that they actually coded 237 unique responses for why folks had last had sex. So you can see there could be physical reasons, stress reduction, pleasure, sensation seeking, or emotional reasons like love, commitment, expression, perhaps very consistent with the model that I just showed, but also other reasons like resource attainment or social status or feeling duty or obligation. So one step you might take with your patients is to say, what are your motivators for sex? What motivates you? Why are you having sex? What are your reasons? And an important take home is that there are largely two categories of reasons. Often negative reasons or avoidance-based reasons, where people are having sex in order to get a negative feeling to go away. Feeling guilt if I don't, feeling fear that my partner might find somebody else to have sex with, or feeling like I'm obligated, I have to do this in order to be a good partner. Or your partner's in a bad mood and they're grouchy or they keep bothering you. And so you give in because that will stop that negative feedback loop. When we have sex for avoidance-based reasons, it undermines our sexual desire. Sometimes low desire in the context of bad sex is common sense. So if you're engaging out of obligation and duty, and you're not really enjoying yourself and you're not feeling aroused and you don't end up with rewards, it makes sense that you're not going to desire to do that again. So assessing motivators, the next step then is looking at what are some of the positives or rewards that you could stand to gain from engaging in sex. That could be a sense of closeness. It could be pleasure. It could be feeling attractive or desirable or feminine or sexy. And that when we engage in sex for rewarding reasons, where we stand to gain something, that will increase our sexual desire and motivation. So what you might take home in terms of influence for your patients is encourage them when their only reason is a negative or avoidance-based reason, that they may be better to say no or to stop having sex if that's the only thing that's happening for them. And to see if they can work toward cultivating more rewards and using that as their motivators. So if they're having difficulty coming up with any rewards, then maybe they could work at figuring out why that is and get some support to increase those access to rewards. And that might be in the form of counseling or sex therapy. So hopefully from that model, there's two take-home messages around reasons for sex and around overemphasis of spontaneous desire, really moving toward understanding responsive desire and how that can be useful and helpful. So my second example is sexual pain. There are a variety of types of pain due to different causes. So in our cancer survivors, we may see dryness, where the vaginal health piece needs to be treated, tightness, and that can be related to scarring or treatments, as well as pelvic floor muscle tension. There can be pain directly at the entrance of the vagina, which often is related to nerve pain, and that can be triggered as well by changes in hormones. There can be depth-related pain, which is more of that kind of collision that's happening from penetrative activities more at the cervix or deeper inside the abdomen, and then more general pelvic pain. And that could be related to pelvic surgeries, scar tissue, ear or bladder-related conditions, or endometriosis, for example. One thing to be aware of is that once you've had a painful experience, anxiety and fear of pain now play a large role in terms of maintaining that pain. So I've even had patients who've had a painful urinary tract infection. It's then resolved, but now they continue to have painful sex, in part due to the fear response that they're experiencing. So let's talk a little bit about the vulvo-vaginal health piece. So in terms of treating vaginal dryness, there are certainly lots of different options here. But I do want to acknowledge that vaginal moisturizing is an important first step, and it is more of a long-term solution. This is different than lubrication, and I'll talk about that in a moment. Moisturizers are used similarly to how we use a face cream. We put it on every day, it restores and makes our tissues healthier. They need to be used consistently, and they are not used for sex. They are used as a part of daily routine to help rejuvenate tissue health. And they have to be used regularly, sometimes even for a month to 2 to 3 months before you may notice that full impact of this treatment. The vast majority of patients I've worked with have said, oh, I tried moisturizers, they didn't work. And then when I ask about how they used them, they might have tried them a handful of times, or maybe once every week or two. and that's simply not enough to get their effect. So they come in multiple forms. They need to be used both vaginally, internally, and externally on the vulval tissues. And there's some evidence that even using natural products like coconut oil and olive oil can also be helpful. Lubricants. In contrast, these are used for sex or for daily activities that can result in pain or friction, and these do not do anything to promote vaginal health tissue. They just decrease friction that could be causing pain. Again, these should be applied both to the vagina, the vulva, and the penetrated object. I will say there's a bunch of different formats. A silicone goes a long way, and it more likely mimics or more closely mimics bodily lubricant, but shouldn't be used with toys or condoms. And water-based, again, are best for people who may be prone to infections and maybe who want to use sexual toys. Lastly, anything that promotes blood flow to the genitals can potentially be helpful. So continuing to maintain sexual activity in a variety of ways, if possible and interested, and that might include non-penetrative activities, vibration, masturbation, massage, anything that's causing arousal can help to maintain the health of those tissues. But it's optimal to make sure that whatever the person is engaging in, that it's enjoyable, that it's creating pleasure, because engaging in it just because it would be good for your body is going to set up a poor relationship, again, when we look at those rewards-based or avoidance-based reasons for sex. In terms of medication management, local estrogen therapy can be really important. Of course, considering some of the administration methods, I learned a lot from my time working in an interdisciplinary sexual health clinic from our nurse practitioners and physicians who followed our patients on local estrogen treatment. So this is not systemic treatment, it's adding topical estrogens directly to the vulva and vagina. That there are a few different methods. So typically when an ovule is inserted internally, that tends to treat the upper third of the vaginal canal, but doesn't do very much for the opening or for the vulva. Whereas creams can be applied with an applicator and then can be rubbed into the vulva, but often these may not treat that upper third of the vagina very well. Other options as well in terms of acknowledging risk to breast cancer or hormonally sensitive cancers, that this is a decision that needs to be made very carefully, sometimes can be appropriate for a very short dose to help rejuvenate tissues and then maintain those gains with non-hormonal vaginal moisturizers. An option is certainly, there's some evidence that estriol can be a bit less potent and less absorbed with the body. So that's certainly an option, but this chart can be helpful in terms of making some of those decisions. Some of our patients' quality of life is so poorly hindered by their pain and discomfort that they may choose to have a short course of local estrogen, even in the context of risk, but that obviously has to be managed on an individual basis and with their healthcare provider. Some other options, intravaginal DHEA or ospemifene. These they're newer and we're seeing more evidence. They have differential approval based on geographic location, Europe, USA, Canada, and very little research in the context of breast cancer as well. But we are seeing some more of these studies that are showing some promise, which is excellent. Ospemifene is also an alternative because it is not a topical treatment, it is an oral treatment. So particularly for those who may have reduced mobility or difficulty with applications directly to the vulva, that is certainly an option. We're seeing more research being conducted on laser types of treatment for vulvovaginal atrophy, but in 2019, there was a warning issued from the FDA around not proceeding with this until further studies are conducted. And even more so, I would say, and particularly in the context of cancer, that we want to be quite careful given the treatments patients have already experienced and the impact on vulvovaginal health. I do see some of these other treatments as well, more so outside of cancer, but certainly lidocaine being used to decrease pain with penetration and has showed some evidence of decreased discomfort and distress. But I would argue that that also increases some difficulty around pleasurable sensation and numbing, and that reliance on lidocaine versus actually working with the pain and managing those symptoms. So I think obviously a multidisciplinary approach is always helpful. And then botulinum toxin in the context of vaginismus to help with relaxation of tight pelvic floor muscles. The research is really showing that this may be best when accompanied with physiotherapy to help with more long-term benefit. So in the realm of psychosocial intervention and sex therapy intervention, I think our biggest suggestion here is really to help patients stop doing what hurts and focus more on what feels good. And that might mean that they need to modify sexual practices. And I'd like to introduce a few options or tools that can be helpful with that. So this is a product that is designed to be worn on a penis or on a penetrating object to decrease the length or the depth of penetration that occurs. And so these are little rings that are, I think the package comes with 4, and you can use 1 or 2 or 4 if needed to decrease that length and decrease the likelihood of that depth-related penetration. Other options include moving away from penetrative activity. So these are some examples of sexual toys that are not focused on internal stimulation, such as dildos. You'll see these offer sexual stimulation. These two, the green one and the purple one, are vibrators. And this pink one in the middle uses an air pulsing technology. One thing I want to highlight, though, is when you introduce these kinds of products or toys, to consider, again, the patient's values. So one of the critiques I have of a lot of sex toys is that they are pink. They are marketed towards cisgender women. Interestingly, this product in the middle is actually called a womanizer. Some people might be okay with that. Other people might not. And so maybe considering some more inclusive of different gender identity types of products, for example, as well. This product can be used externally. It can also be used within partnered sex, regardless of genders, to be inserted between 2 body parts, 2 genitals, where the vibration is then directly provided to both sets of genitals. And there's a great little line of products that are very much gender inclusive. And you'll see the brand name here, that go onto their website and check out their line of products, but they're really marketed to not be, pink and cis heteronormative, designed for women. So do consider that. Lastly, a referral to pelvic floor physiotherapy is probably in everyone's best interest when dealing with sexual pain. I love working with pelvic floor physios in my practice. I often think about it that I'm working from the top down and they're working from the bottom up, and we can support our patients really adequately in delivering treatment from both of those directions. And through the course of pelvic floor physiotherapy or through sex therapy, there may be some discussion about possible dilation therapy. And you'll see through this image that these are a series of sequentially sized insertable objects that can help to treat a number of things. One is during or following radiation therapy. There's some evidence that this can be helpful with reducing development of scar tissue, as well as managing pain and tolerance in terms of building up one's capacity around pelvic floor muscle tension. But I would say probably one of the most important things I notice is a building up of confidence. So if people are able to accommodate a certain size of dilator on their own, and they know that that's the same as their partner size or the object they want to use, that they can feel much more confident that, hey, I was able to manage this on my own with minimal pain. I can manage this in this sexual context. Because as we know, it's very different to engage in activity with a partner, particularly when those parts are attached to another human being versus when we may be able to control them in terms of depth and speed and readiness. So I find dilation can actually be a really important thing around confidence. But again, adherence can be challenging, and it may need to be introduced in a values consistent way with the patient. For some, marketing that as a sexual pleasure tool is exactly what they need. For others, it would make them extremely uncomfortable to think about this as any kind of masturbatory or pleasure-based activity, and it needs to be introduced as a medical intervention or a physiotherapy for them to be able to get on board with using it. So I do think that having a conversation about how that best would meet the patient's need in terms of introduction is also really important. So hopefully you've got a good sense of what some of the different ideas are around treatments. Certainly, I'm not expecting anybody following today's presentation to feel like they know everything about all of these different options, but I also think it's important that you know what is out there so that you can refer patients. You might say, oh, I've learned about dilation. Why don't you go see a pelvic floor PT and discuss that? Or I've learned about how important it is to challenge our beliefs and assumptions about sexuality. Maybe seeing a counselor would be helpful. So hopefully giving you an idea of what some of those options are that are out there. I'll stop now and take some time for questions. Just wanting to as well give you the information about email. If you have any questions, you can follow up directly with me. You can follow me on Instagram, where you can see I'm trying to translate what we know about science into messages that people can actually put into practice in their daily lives. And of any of the products or toys that you saw today, there is a local company that has been kind enough to kind of curate a little toy box for me where everything's on one website. But I do not receive any any profit from that. It's just a simple way of keeping things more organized for me and for my practice. So I will pause now, and Morgan, if you can help me with questions, that would be great.
Yes, thank you so much, Dr. Walker. We will now take some time for questions, so please be sure to post those in the Q&A box at the bottom of your toolbar or in the chat, whichever is easier for you. And I actually received a few emails already, Dr. Walker, asking on distribution of slides.
Yeah, I'm happy to send you a slide deck. I just need to do a little bit of reorganizing because some of my animations will cover up text. So I'll do that and I'll send it out to you today.
Perfect. Okay, great. Thank you. While we wait for those questions to come in, I actually thought it was pretty interesting that you noted that fewer than 50% of gynecologists gathered the sexual history of patients. And I feel like that would be something, I mean, I know it's a difficult subject to talk about, but I feel like that would be something that's pretty important data and information to know about the patient in moving forward in treatment or any medicine or anything moving forward.
I do find, so that stat was for gynecological oncologists. So I do think that they are spending lots of time discussing surgery and chemotherapy and cancer treatment, and they may not feel they have a lot of time to gather that history. But I also think if we're not gathering a history, we don't understand which of our patients have experienced trauma. And if you've experienced any kind of trauma, but in particular sexual trauma, and now you're being treated for a gynecological cancer, you're going to be particularly at risk of experiencing difficulties with those treatments and emotional reactions during those treatments. And so I know a lot of people feel reluctant to ask about trauma because then they think I've opened this can of worms and now is this patient going to break down in my office and I only have 10 minutes before I see the next patient. But really, I think we need to think about ways of saying in more of a matter-of-fact way, is there any trauma in your history that you'd like me to know about as we prepare for your treatment? It's not that you have to treat that trauma, send them to psychology if they want it, but also just so that we're better informed about how to provide that care to patients, because they may need more time, they may need special extra kind of attention, asking for consent more often as you engage in these procedures in order to make sure that they feel safe and that they can stop and slow things down if needed.
Mm-hmm. So important. And then following with that, I thought it was amazing your perspective on just the whole importance of confidence and just keeping that up and keeping that momentum going in all, and that goes to like everything in your life, with everything in confidence, but just an amazing thing to remind yourself of, just to keep moving forward in whatever is comfortable to you and what's safe to you. That's the most important thing. Okay, we have a question. Excuse me if I say these incorrectly. Are prosterone and it's medicine and osemifene available in Canada?
So I think I was looking all this up recently to make sure that I'm up to date, because the last talk I gave was a little bit older. Intravaginal DHEA is available in the United States, not in Canada, but we'll likely see that hopefully, perhaps in the future. Also, ospemifene is available. So the latest thing I was reading was in June. They're working on getting public drug coverage access. So I do believe it is available for postmenopausal women, but not necessarily approved in the context of cancer specifically. So hopefully we'll see more studies to support that. But again, if anyone else knows if this is more your practice area, you may know even better than I am. I try to stay up to date, but also I'm not a physician. So it's good to know what's out there as a possibility, what's being used. Again, recognizing that we've got people from all over the place joining our webinar today and people who will stream it later as well.
Someone mentioned it, very informative. They work in gynecologist oncology as a counselor, LCSW, and it makes them realize that they need to ask every single patient. I guess some of the information that we talked about today.
Absolutely. And I know there's a lot of fear around what happens when I ask and what do I do with that, but I don't think that patients have a problem when we say, this isn't my expertise, but I'm happy to help refer you or provide other resources, send you to other places if needed. But certainly, again, the onus is not on you to solve their trauma. It's to provide care in a way that is respectful and informed of their trauma.
Mm-hmm. Okay. I think that's all we have for today, unless any more questions pop into the Q&A. But if not, thank you, Dr. Walker, for amazing presentation, for joining us today. And reminder that it is recorded. It will be posted on YouTube. And be sure to follow Dr. Lauren on her Instagram and follow up with her email, as well as SIO's Instagram, to see the recording posted, a direct link. And we will also follow up with the attendees on those slides.
Awesome. Thanks for having me, Morgan.
Thank you. Thank you, everybody. Have a great day.